Bismillahirrahmanirrahim. Quote for the day is truth has come and falsehood has vanished. Indeed, falsehood is ever bound to vanish. The topic for today's presentation is health sector reforms and public-private partnerships. I am Dr. Ayesha Amin, PGR of FCPS Community Medicine at Institute of Public Health, and I will be presenting this under the kind supervision of my supervisor and teacher, Professor Dr. Saira Afzal, who is the Dean of IPH Lahore. So the learning outline for today's presentation is introduction to the health sector reforms, type of health sector reforms, requirement for health sector reforms, challenges and health sector reforms in Pakistan, the public-private partnerships, and multiple choice questions. Learning outcome. By the end of this presentation, the participants would be able to describe about the importance of health sector reform, its type, health sector reforms in Pakistan, its achievement and challenges, and to be able to answer the multiple choice questions. Introduction. The first component is the health sector reforms. Health sector reform is defined as sustained, purposeful, and fundamental challenges to improve the efficiency, equity, and effectiveness of the health sector. Sustained in a sense that it is not a one shot temporary effort that will not have enduring impact. Purposeful in the sense of emerging from a rational, planned, and evidence based process. And fundamental is the sense of addressing significant strategic dimensions of the health system. So the rationale for the health sector reform is first is current health system challenges which include inefficiency, the poor use of resources, weak referral systems, overcrowded tertiary care hospitals with the weak primary health care, and duplication and wastage of resources, inequity in between the rural and urban areas, income-based differences, and marginalized groups are often underserved. Poor quality of care, lack of standards and protocol, medical error and weak accountability, and low patient satisfaction. The financial barriers, which include high out of pocket expenditures, catastrophic health spendings, and limited insurance coverage. The next is epidemiological transition, shifting from the communicable diseases to non communicable diseases and increased chronic disease burdens. The demographic pressure, which include rapid population growth, aging population, and urbanization, and political and economic drivers which include the government policy shift, fiscal constraints, global commitment, universal health coverage, and sustainable developmental goals, and public demand for accountability. The importance of health sector reforms. The reforms are needed to improve the efficiency and cost effectiveness, to ensure equitable access like universal health coverage, to strengthen the quality assurance and governance mechanism for financial protection and risk pooling, and for integrated long-term preventive care system, to expand the coverage and ensure sustainability, and for system sustainability and political legitimacy. Types of health sector reforms. The health sector reforms are classified as either big R, that is the reforms which are major and system reforms, or small reforms which are incremental or operational reform. The systemic reforms are basically large scale structural transformation of the entire health system. They are the fundamental policy or legislative changes, and they are basically there is system wide restructuring of the health system. There is long term political commitment, and major financial implications are present in the systematic reforms, and they are often nationally driven. Examples are introduction of the universal health coverage, national health insurance system, decentralization of the health system, or privatization of the public hospitals. The overall goal of these big reforms is to transform the structure, financing, and governance of the health system. While the small reforms are basically the gradual targeted improvements within the existing structures and they have limited scope, there are technical or managerial changes. They are short to medium term focus. They have less political resistance and they focus on the performance improvement. The examples include introducing clinical guidelines, improving drug procurement systems, implementing electronic health record, and staff training programs. And the overall goal of these small reforms is to improve the efficiency, quality, or service delivery without changing the entire health system. The health sector reforms are also classified as the reforms which are taken place within the health system, and these include the organizational and legislative policy reforms, while the reforms which take outside the health system include the structure or the financial reforms. Coming to the structural reform, these are the changes in the overall structure and the governance of the health system. And the purpose of these reform is to improve the efficiency, increase accountability, and enhance the responsiveness to the local needs. Examples include decentralization, transferring of authority from central government to the provincial or district levels, and privatization, shifting service delivery from public to private sector, or electronic procurement reforms. The next is legislative and policy reforms, which is defined as the introduction or revision of the laws and national health policy. The purpose of these reforms is to provide legal framework, strengthen governance, and ensure standardization and regulation. Examples include national health policy updates, public health acts, regulation of private sector, and drug regulatory laws. The next are the organizational reforms, which include improvement in the management and internal functioning of the health institution. The purpose is to improve the efficiency, enhance service quality, and strengthen accountability. The examples are hospital autonomy, performance management system, decentralization, quality assurance program, and strengthening of the referral system. The next type of reforms are the financial reforms, which are changes in how the health services are funded and paid for. The purpose is to reduce out of pocket expenditure, improve financial protection, and ensure sustainable funding. The examples are health insurance schemes, risk pooling mechanism, strategic purchasing, and performance based financing. Now, the health sector reforms in Pakistan, the reforms were proposed in the direction of four based categories, namely reforms within the health sector, overarching measures, reconfiguration of health within an intersectoral scope, and generating evidence for reforms. So the major reforms which took place in Pakistan were devolution reform, which took place in 2010, the health financing reforms, the primary healthcare strengthening reforms, governance and institutional reforms, and digital and health information reforms. So the first is devolution reform, which took place in 2010. 18th Amendment of the Constitution of Pakistan shifted health from federal to the provincial responsibility. The impact of this reform was that province gained autonomy, policy fragmentation increased, there was provincial health strategies developed, and the capacity gap they were emerged at provincial level. The next was health financing reforms, which include the launching of the Sehat Sahulat program, and it is basically a type of government-funded health insurance. The target is basically poor and vulnerable family, and it gives coverage to the secondary and tertiary care facilities like surgery, maternity, and dialysis patient. And the overall goal of these reforms is to have financial protection and move towards the universal health coverage. The next reform were the primary healthcare strengthening reform, which were done basically to revitalization of the basic health unit and rural health centers, the expanded program of immunization strengthening, lady health worker program expansion, and integration of the maternal neonatal child health services. The other were the governance and institutional reforms, which include the National Health Service regulation and coordination, the development of the regulatory framework, the strengthening of the Drug Regulatory Authority, the hospital autonomy reforms in provinces, and public-private partnerships. The digital and health information reforms were introduction of the district health information system, that is DHIS2, the electronic medical record system in tertiary hospitals, the telemedicine initiatives, and NADRA linked health insurance databases. They were all the reforms which took place in the category of digital and health information reforms. So the achievement of these health sector reform is that it increased financial protection. The insurance coverage expansion basically lead to the increased financial protection. There were greater provincial ownership for health policies. There was improved immunization coverage in many districts. There were expansion of the health infrastructure in some provinces. While again, there are certain challenges with the introduction of the reform. That is, the first and important was the fragmentation, which took place after devolution. There were sustainability issues for the insurance and financing. The persistent out-of-pocket expenditure are still there despite all of these initiatives. The weak regulation of the private sector is a major issue. Then health sector shortages, HR shortages in rural areas, political instability affecting continuity because of the changing governments, and interference by the provincial political elites, which also affects the implementation of policies and weakens the system. The next part is about the public-private partnerships. Introduction. The WHO described partnership as a mean to bring together a set of actors for the common goal for improving the health of population based on mutually agreed roles and principles. The public-private partnerships are interface arrangements that bring together organization within the mandate to offer public good on the one hand, and those that could facilitate this goal through this provision of resources, technical expertise, or outreach on the other hand. Not all public private partnerships can qualify to be called partnerships, as this is a value laden connotation. In public private partnerships, risk, responsibilities, and rewards are shared between both partners. So these are the 7 essential conditions that define the public-private partnerships. The first is arrangement between the public and private actors or parties, risk sharing optimally between the contracting parties, then supply and provision of services for public benefit by private partner, standards focus on quality of services and performances, investment in and or management of public assets by private partners, payment linked to performance, and then time period for a specified duration of time. So, why to use a public-private partnership? Why government prefer these partnership? Because of limited public funds, improve efficiency and innovation. It leads to the faster project completion. It provides better management expertise, and it improved the overall quality of the services. The key features of a public-private partnership that it is a long-term contract, usually about 10 to 30 years. There is risk sharing between the public and private sector. It involves the feature of performance-based payments. The private sector in investment and expertise are utilized. The public sector regulation and oversight plays a major role. And then overall, it focuses on the service delivery and not just the infrastructure development. So the categories of public-private partnership, they can be product-based partnership that enables the access product donation programs, for example, childhood immunization, product development partnership for discovery or commercialization, for example, the malaria vaccine initiative, or they can be system-based partnerships which support government for the health system strengthening. So there are a few types of public-private partnership models that are used at different places. The different models are applied at different places. So the public-private partnership models differ based on who designs, finance, builds, owns, operates, and then transfer the project. The key difference is at the risk sharing and ownership structure. The common public-private partnership models are build, operate, transfer, build, own, operate, design, build, finance, operate model, service contract model, management contract, and then lease or aforementioned model. So the first model is build, operate, transfer model. The private company, it builds and operate a facility for a fixed period, and then it eventually transfers this to the government. So the ownership during contract lies with the private sector, and after the contract, the government takes the ownership. The risk in this type of models is that there are construction and operational risk, and it are mostly private, and it is commonly seen these type of models, they are applied in hospitals. The next is build, own, operate. In this type of model, the private sector, it builds, owns, and operates permanently. So the ownership lies with the private sector. The risk is associated with the private sector, and the government only regulates. The role of government is to regulate the project, and it is used in specialized hospitals and diagnostic centers. The next type of model is design, build, finance, and operate, DBFO model, and it is a private partner design, build, finance, and operates the facility. The ownership usually lies with the initially with the private sector, and it is the ownership is then transferred after the contract. The risk is major risk with the private sector, and it is usually a long-term contract of 20 to 30 years, and it is highly structured and common in modern public-private partnership projects. The next is service contract model. The government, it hires a private company to provide a specific service for a short time period of 1 to 3 years, used when government wants efficiency in a specific function only. The ownership is with government, and the risk is mostly with the government. And examples in health include the outsourcing laboratory services in DHU and THU hospitals, private company providing diagnostic tests like CBC, X-rays, or CT scans. So in this type of models, the government pays the per test fee or the fixed fee. So the government owns the hospital while the private company, they only runs the lab. The next is the management contract. The private sector, it manages the facility, but government finance and owns it. So the ownership lies with the government. The risk is the operational risk sharing. And examples is NGO, that is non-government organizations managing a basic health unit. So this type of model in which a private sector is given the authority to manage the facility is known as the managerial or management contract, and it is used when the government lacks the management capacity. Then there is a lease model. There is private partly lease a public facility and operate it. They collect user fees. The ownership is with the government, and the duration of these are medium term, like 8 to 15 years, and it is used when the government wants better operational efficiencies. So this is the diagram which is basically showing the comparison of all the public-private partnership models. And we can see that the first three, like service contract, management contract, and the lease model, the ownership and financing lies with the government. While in rest of the three models, that is build or transfer, build, own, operate, and DBFO model, the ownership and financing is with the government. And these type of model in which the ownership and financing is with the government, they are basically the duration of these kind of model is long, while the service and management contract are the short and medium term type of comparison models. So the public-private partnership in Pakistan health sector, Sehat Sahulat program is the government-funded health insurance program. Private hospitals empanelment is there, and there is free treatment of the poor families, and the public-private partnership between government and insurance companies. The next is Indus Hospital and the Health Network. Again, this is a public-private collaboration, and it provides free of cost tertiary care services, and it is supported by donors and partners. The next is Punjab Health and Population Department, which has performance-based contracts, and which include also the outsourcing of the BHU and NRCs. So NGOs managing the public facilities, the National Action Plan for the Prevention and Control of the NCDs and Health Promotion, Save the Children and Family, and the next initiative is the Save the Children and Family Planning Association of Pakistan in MCH activities. So NGOs having outreach and access, which basically enhance the mobile delivery services, including the leprosy control and HIV. So advantages of these public-private partnership is that it reduce burden on government budget, improve efficiency, bring innovation and technology. There is better service quality, expand access to care, avoid duplication of services, establish norms for service for both sectors, involve communities, enhance political clout, bring new resources, and there is risk sharing. While again, there are disadvantages as well. There is of profit over patient care. There is weak regulation in many cases. There is complex contracts. Long-term financial commitments are there. Less powerful partner may feel loss of control. There is loss of identity as well. There is also blame game is present. It requires extra effort by managers, and there is which leads to the political risk, and there is conflict of interest, may lead to the corruption in many cases. Recent update. So this was an article which was published in Curious in 2023, and it says that towards sustainable healthcare system, a low and middle income country's case for investing in health care reforms. So Pakistan, a low and middle income country, faces challenges in providing sustainable care to its population due to inadequate financing, weak healthcare infrastructure, and inefficient human resource. So for this, they did a literature review, and they've recommended the strategies. So to achieve the sustainable healthcare system in Pakistan, we recommend comprehensive healthcare financing policies, including increasing budgetary allocations for health, social health protection through universal coverage, and supporting health and economic developmental process. Service delivery can be improved through restructuring public healthcare facilities, incorporating behavioral and social health determinants into primary healthcare, aligning healthcare delivery within the community, and promoting collaborative leadership between the public and private sector. The use of ICT can be explained by implementing e-health policies, disseminating authentic public health information, and enabling telemedicine services. Effective healthcare governance and leadership can be promoted through meritorious, transparent, and accountable reforms, stable healthcare structure at all community levels, and appropriate health policy and organizational framework. And strengthening of the human resource can be achieved through compliant policy implementation and revision in laws and policy governing medical teaching institutions. So this article basically provides the strategies which can be applied to all the 6 dimensions of the health system, in which the reforms can be applied. Now it's time for multiple choice question. The first MCQ is: a government builds a hospital through a private firm that finance, constructs, and operate it for 5 years before transferring it back. Which risk is mainly borne by the private partner? A. Political risk. B. Regulatory risk. C. Operational risk. D. Sovereignty risk. And E. Policy formulation risk. So the right answer is C, operational risk. The second MCQ is: a provincial government outsource laboratory services in DHQ hospitals to improve efficiency while retaining ownership and financing. Which PP model is being applied? A, build, operate, transfer. B, management contract. C, concession. D, service contract. E, build, own, operate.
D.
Let me check again. Yes, D is the right answer. Next is: an NGO is contracted to manage basic health unit. The government funds salaries and infrastructures, but operational management is delegated. This reforms aims to: A, privatize primary care. B, improve managerial efficiency. C, increase hospital revenue. D, transfer ownership to NGO. E, eliminate public funding. The right answer is B, improve managerial efficiency. The fourth MCQ: a reform introduced electronic health record via partnership with a tech company, improving transparency and monitoring. This primarily enhances: A, stewardship function. B, revenue generation. C, capital expenditure. D, infrastructure ownership. D, taxation policy.
D.
D.
The right answer is A, it leads to the stewardship function basically. A country moves from infrastructure-focused public-private partnership to outcome-based maternal health contracts. This represents shift toward: A, capital-intensive reform. B, performance-oriented reform. C, assist privatization. D, output-oriented reform. E, regulatory withdrawal.
B.
The right answer is B, performance-oriented reform. Sixth is a public-private partnership telemedicine project connects remote BHUs with urban specialities through private IT providers. The primary reform objective is: A, revenue maximization. B, equity improvement. C, administrative downsizing. D, privatization of facilities. D, E, budget reduction.
D.
The right answer is basically B, because they are connecting the rural side to the urban specialist, so it leads to the equity improvement. The seventh MCQ is: a country facing high out-of-pocket expenditure introduces a public funding insurance scheme contracting both public and private providers. The reform mainly strengthened which health system function? So, A, service provision. B, medical education. C, revenue pooling. D, infrastructure ownership. E, pharmaceutical production.
C.
Yes, C is the right answer. The eighth MCQ is: a private company builds and permanently owns a diagnostic imaging center with a hospital campus under regulation. Which public-private partnership model applies? A, BOT, that is build, operate, transfer. Build, operate, build, own, operate. Concession, lease, or management contract.
Lease.
So the right answer is basically B, in which the private company it builds and it permanently owns a diagnostic center. So it is basically the B option: builds, owns, and operates. The ninth MCQ is: long-term health sector reform success in Pakistan depends most on: A, expanding tertiary care. B, centralizing government. C, eliminating private sector. D, sustainable financing. E, enhancing digitalization.
Delta. D.
Yeah, the right answer is E, as per Mikey, that is enhancing digitalization. Because if when we have a central hub for the data set, then we can make sustained reforms. The last MCQ is: a province struggles with rural doctor absenteeism despite increased salary packages. Which reform approach would be most effective? A, introduce performance-based incentives contract linked to attendance. B, implement strict biometric monitoring and accountability system. C, provide rural hardship allowance with service-bound requirements. E, strengthen supportive supervision and periodic performance appraisal. E, increase base salary uniformly across all districts.
A.
Yes, A is the right answer. This is the key to all MCQs. These are the references. This is the official channel of the YouTube of Institute of Public Health, where the recording of this presentation will be uploaded. Thank you for your patient listening and sorry for the inconvenience.
Thank you, Dr. Ayesha. Very nice presentation, and you have given us a very important insight into different models and how we can go for public-private partnerships, about the operations of